Hi, my name is Dr. Thomas Devlin. I'm a professor of neurology at the University of Tennessee Health Science Center, and today I'm joined by my colleague, Dr. Teresa Civilis.
Hi, I'm Dr. Teresa Civilis, and I'm the Director of Research with TeleSpecialists.
Today, we'd like to tell you about the results of the VALIDATE study, validation of artificial intelligence to limit delays in acute stroke treatment and endovascular therapy. Viz is in over 1,300 hospitals around the United States. There have been numerous studies done to date showing the benefit of Viz on improving stroke workflow. The studies to date have been limited by being largely single center studies. Their trial designs were serial cohort studies looking at the workflow metrics before Viz was installed, comparing it to after Viz was installed, often with months or years between the data collection in the two cohorts. In addition, the single center studies that have been done have often looked at metrics that Viz does not directly control, such as door in and door out time and door in to table time. In the VALIDATE study, we specifically designed a more scientifically rigorous trial that measured a Viz specific effect.
The VALIDATE study workflow, we chose to look at the arrival to notification of neurointerventionalist time, and in doing so, we excluded any facilities in which the neurointerventionalist was not notified by a neurologist, or if they used a non-Viz AI tool, as we then divided the groups of patients into those facilities utilizing Viz AI versus those utilizing standard processing of imaging through radiology. We were able to enroll 14,116 patients in this study from 17 states and 166 facilities.
Here are the primary results of VALIDATE. What we found in this parallel cohort study was that there was a 39.5-minute faster time from patient arrival to the contacting the interventionist in the Viz-enabled hospitals compared to those centers that did not use the AI. This was statistically significant at less than 0.001. And importantly, we saw not only a much faster time, but the variation of the data was much tighter in the Viz-enabled hospitals. So in these bar graph, you can see that there was much less variation in the time to calling the interventionist in those centers that had the Viz technology. We then looked specifically to see if there was a Viz effect at patients presenting to the spoke hospital versus presenting to the hub hospitals directly. What we found was, much like what we saw in the combined analysis, that if patients presented first to the non-thrombectomy centers, there still was a statistically significant faster time to calling the interventionist at the 0.001 level, and similarly when patients presented directly to the thrombectomy centers. So overall, in all three of these categories of the combined spoke and hub, in patients presenting to the spoke or patients presenting to the thrombectomy capable centers directly, in each case, a statistically significant faster time to contacting the interventionist at the less than 0.001 level. In conclusion, this 17-state, 166-site study corroborated the results of previous smaller studies that concluded a statistically significant benefit of Viz at driving faster LVO detection and overall patient workflow. This was an independently funded study funded by TeleSpecialists and the nonprofit Neuroscience Innovation Foundation.